who has green, you don't have to take any action. Someone who's amber, modify his lifestyle, plus go for DIXA to tell you whether you are going to treat him or not. Someone who has red one, you have to treat him immediately. Do not wait for DEXA scan. Did you get that, Dr. Shaheen?
Yes, ma'am. Very well explained. Thank you.
Okay, the second question, yes. The second question regarding the alendronate, why the alendronate would be better than zoledronate. Zoledronate, mainly it's parenteral, it's a parenteral route. Alendronate, it's tablet. The second thing, zoledronate will carry lots of side effects like esophagitis, like jaw necrosis. These side effects would be less with alendronate.
Right.
The third thing, that based on the studies, the alendronate would be more effective rather than zoledronate. Is it clear?
Yes, ma'am. Thank you.
Okay. Any other question?
Hello, ma'am. So,
Wa alaikum salam. Yes, Dr. Samsuna.
See, once I heard that she has celiac disease. Do
Yep.
I want to clarify about polyglandular syndrome, the other autoimmune affections like
Okay,
primary
so-
disease?
So this is within your systemic review, and from the systemic review, doesn't seems that the patient like has any other symptoms. So there is no any other skin changes apart from dermatitis herpetiform. So there is no vitiligo and so on. The patient doesn't seems to have any kind of Addison disease because her weight is good. However, Dr. Kumal didn't ask about postural hypotension, didn't ask about skin tanning in like particular. However, it doesn't seem to have other autoimmune association. She asked about past medical history. There is no past medical history. However, she has a positive family history of diabetes.
Okay, ma'am. Thank you. Thank you very much.
You're welcome. Any other question?
Yes, ma'am. Ma'am, what's that rash on elbow? Dermatitis herpetiform?
Dermatitis herpetiform, yes. Yes, Dr. Dot.
Excuse me, I just
Yes.
wanna clarify that in celiac there is deficiency of vitamin D, so it will lead to osteomalacia. So why were we emphasizing on osteoporosis in this case? Due to postmenopausal, or is it related to celiac disease?
So this is the point, doctor, that I've told Dr. Kumal about it. We don't know whether the patient got osteomalacia or osteoporosis. Still, we cannot differentiate that from the history only. Did you get that?
Yeah, you can't.
Okay. So the patient has vitamin D deficiency that can lead to osteomalacia, and the patient will have low calcium that can lead to osteoporosis. Plus the patient postmenopausal lady, which can lead to osteoporosis again. So you don't know where you are lying. Is it clear, doctor?
Yes, and my second question is, first we heard that zoledronic acid is preferred, and later we heard that alendronate has more good profile, safety profile. So which one is preferred? Is it alendronate or zoledronic acid?
Well, the preferred one is alendronate, alendronic acid. It's not the zoledronate. So you've told me it's better effective, the zoledronate.
Yeah, and actually Komal answered zoledronate. And you said yes, correct. So we were confused.
Dr. Shaheen, I'm struggling to hear you. I don't know whether it's my own problem or...
Ma'am, actually we heard zoledronate first. Komal answered zoledronate.
Zoledronate. No, the answer used to be in the exam, alendronate, but let me check that, guys, and I'm going to be back for you. Okay, let me just recheck that, and I'll post it in the group if there is any changes. Any other question? Okay, great. Seems no questions. So let's move to the next case. And Dr. Ratna, are you here?
Yes, ma'am.
Okay, so this is your case and it's a station 4 case. You will have 3 minutes to prepare your thoughts and go. Okay, time up. Are you ready?
Yes, ma'am.
And go. And this case from the start as well 2 weeks ago. And go.
Hello, good morning.
Hello, good morning.
Myself, Dr. Ratna. I'm the doctor in the oncology clinic. Can I confirm that you are Mr. Adam William and you are 45 years old?
Yes, doctor, I am. Dr. Ratna, please raise your voice.
Mr. Adam, is it okay, ma'am? Mr. Adam? Hello?
It's not totally okay for me. I don't know for the other candidates. Can you hear Dr. Ratna clearly, guys?
No, very
Low. Voice is low.
Now, ma'am?
Okay. It's still low. Would you
Hello.
be able to solve that, Dr. Ratna?
Hello?
Yep. So raise
okay,
your
ma'am?
voice, please. Then it's better. So let's resume.
Hello, good morning.
Good morning.
I'm Dr. Ratna. I'm one of the doctor in the oncology clinic today. Can I confirm that you are Mr. Adam William and you're 44-year-old?
Yes, doctor, I am.
Mr. Adam, nice to meet you.
Likewise, doctor.
Mr. Adam William, today we are here to discuss regarding your health condition. Is it okay?
Yes, sure, doctor.
Mr. Adam William, can I ask you what is your understanding regarding your health condition till now?
Well, doctor, I have been experiencing weight loss and fever recently for the past few weeks, and I feel like fatigued all the time. Then I've noticed some lumps. Then I was wondering what's wrong with me. So I sought medical advice, and my GP referred me to the doctors who took some snap tests from these lumps, and they did some investigations and bloods of me. And I'm just wondering what's the result of all of these tests.
Mr. William, today we have the results of the test. Before discussing with you, can I ask you, do you have any particular expectations from our meeting today?
Well, doctor, I'm really afraid from the new variant of COVID-19.
Pardon? Sorry?
I'm afraid from the new variant of COVID-19 virus.
Mr. Adam, you're not having any COVID infection, but I don't have a good news for you. Sorry to say this.
Oh, what do you mean, doctor?
Mr. Adam, we got the results of the SNP test, and the result is showing a form of cancer of your nodes, what we call it as Hodgkin's lymphoma. Sorry to say this.
Oh, doctor. So, are you sure about this diagnosis?
Mr. Adam, I'm sure about the diagnosis.
Oh, this is really bad, doctor. So, am I dying now?
Mr. Adam, I really appreciate your concern, Mr. Adam. Mr. Adam, can I explain you more about this?
Yes, please, doctor.
Mr. Adam, you're diagnosed with a condition what you call it as Hodgkin's lymphoma. Okay, this is a type of cancer involving our nodes, lymph nodes. Okay, which is a part of our defense system, which acts against our bugs. Okay, because of the cancer, you have developed enlarged these lumps. Okay, I'll draw the picture for the patient.
Mm-hmm.
The nodes, enlarged nodes. Are you with me, Mr. Adam?
Yes, doctor. Continue, please.
Mr. Adam, because of the cancer of these nodes, okay, this will lead to this has led to your weight loss and your night sweating, okay,
Mm-hmm.
and enlarged your nodes, okay, for which our consultants have decided to start you on treatment, what you call it as chemotherapy. Okay.
Is it curable, doctor?
Mr. Adam, I really appreciate your concern, Mr. Adam. Mr. Adam, if the condition is picked up early and started treatment early, there is a good prognosis.
What do you mean, doctor?
If the condition is picked up early and the treatment is started early, this can be cured.
Okay, so do you think that you've picked this early, doctor?
Pardon?
Do you think that you picked up my cancer in early stage, doctor?
Mr. Adam, I really appreciate your concern. Mr. Adam, as your with our investigations, it's confirmed that the disease is not spread to other organs.
Okay.
Can I go about it? What is the treatment plan?
Yes, doctor.
Before going to the management, I'll ask you a few more personal questions. Is it okay?
Yes.
What do you do for a living, Mr. Adam?
I'm working in a kindergarten, doctor.
With whom you are living?
I'm living with my wife.
Do you have enough? Is this problem affecting your daily activities?
Yes, doctor. I feel fatigued all the time. I wouldn't be able to cope with my life anymore.
Mr. Adam William, we are here to help you regarding this. We can involve our occupational worker who can help you in the problem what you're facing at the job front. Do you have enough support at home?
Yes, doctor. My wife, she's really supportive.
Do you have any? Do you need any financial support? Are you having enough financial support?
Yes, doctor.
Mr. Adam William, do you smoke?
No.
Sir, do you consume alcohol?
Yes, doctor.
Can I know how much?
I've never exceeded the permissible limit, doctor.
Okay, Mr. Adam. Mr. Adam, can I go about the management plan?
Yes, doctor. I've told you yes.
Mr. Adam, you'll be starting on a treatment plan, what we call it as chemotherapy, where the medication, the cancer medications, will be given through one of the through your blood channels. Okay.
Okay, doctor, but I'm afraid of this chemotherapy, doctor. So do you think that I can lose my hair?
Mr. Adam, I really appreciate your concerns, Mr. Adam. Mr. Adam, as this chemotherapy, these drugs mainly affects the rapidly growing cells, okay, like the cancer cells. It will affect rapidly growing cells like our hair and even our gut lining, okay, our bowel lining, okay, because of which you may have some hair loss.
Mm-hmm.
Are you there with me?
Yes, yes, doctor. And what do you mean by gut lining, doctor? I didn't get that.
It may affect our, as it's affecting our hair, you may have some, it may affect the linings of our bowel, okay, because of which you may have some tummy discomfort and you may have some loose bowels also, okay. Are you with me?
Yes, doctor.
Any other concerns you have?
But it seems something really frustrating in the future, doctor.
Mr. Adam, I really appreciate your concern, Mr. Adam, but we are here to give full continuous support, okay? And you'll be monitored for all these side effects, and we give you full support, like in the form of if you, for the hair loss, we can provide you with artificial hair, okay? Are you with me?
Yes, yes, doctor.
Mr. Adam, want to say one more thing. This chemotherapy, the medications, what we give, the cancer medications, will be given through a line, which is placed in our one of the blood channels, what we call it as Hickman line. Can I explain you more about it?
Yes, sure, doctor.
Mr. Adam, here one of the tube, okay, will be placed in one of the blood channels, okay, through which we'll be giving the cancer medications, okay. This will be this line will be placed by one of highly trained staff of our team who are well qualified and who will be doing this procedure regularly. Okay. Before doing the procedure, we'll be doing few blood investigations to know if there is any problem in your blood. Okay, and it will be done in a quiet room. Okay, and the area where the line is inserted, okay, will be numb. Okay, and the line is placed under image guidance, and the line will be placed. And once the line is placed, it will be secured to the skin. Is it okay?
Well, doctor, I didn't get that. Why you are going to do all of these procedures? I've received antibiotic previously and the fixed line on my blood channels as well, and nobody explaining all of these steps for me.
Mr. Adam William, I really have to concern regarding this, Mr. Adam. Here, the cancer medications will be given in repeated cycles, okay? And if we give through the regular channel, okay, it may be get blocked, okay? It may lead to some irritation of those blood channels, leading to an infection, okay? You may have some irritation, you may have pain if you use this, and as you need repeated administration of this drug during the cycle, so we are planning this line for you. Hello.
Okay, doctor.
This I want to say one more thing. If before putting the Hickman lines, okay, we'll be explaining you once again, okay, and you need to sign the consent form. Is it okay?
Okay.
And sometimes there may be some complications, like it may get blocked, okay, there may be leakage from the light, okay, and there may be bleeding, okay, but we are here to monitor it and detect any complications as early as possible. Is it okay with you? Or get infected, you may have some
2
fever,
minutes remaining.
redness at the side. Is it okay with you?
Okay, doctor.
Mr. Adam, can I summarize for you?
So, doctor, yeah, sure, you can summarize.
Mr. Adam, you're diagnosed with a condition what we call as Hodgkin's lymphoma. It's a cancer of one of our nodes, and our multidisciplinary team has decided to start you on a treatment what we call as chemotherapy, and for which we need to place a line for the administration of the chemotherapy line, what we call the treatment line. Do you have any concerns for me?
Well, doctor, I'm just concerned that you've told me that I have to receive the chemotherapy. So, am I going to lose my ability to have children in the future?
Mr. Adam, there is a possibility of. I really appreciate your concern regarding this, Mr. Adam. There is a possibility, so we'll be referring you to our doctor, okay, where before the starting of chemotherapy, we can store your sperms, which can be used at the later stage. Is it okay with you?
Okay, doctor.
Any other concerns you have, Mr. Adam?
When you are going to start the chemotherapy for me, doctor?
I really appreciate your concern, Mr. Adam. We'll be starting as early as possible.
Mm-hmm.
As early as possible. Can I know what did you get from our meeting till now?
Oh, well, doctor, I've just got that you've diagnosed me with a kind of cancer, and you would like to start me on chemotherapy, and before that you would like just to do some procedure, and you would like to have my consent for that. And time up. Okay, so doctor, what's your scenario about?
My scenario was Mr. Adam.
Dr. Ratna, I'm struggling to hear you, and I think everyone else got the same problem.
Ma'am, now, ma'am. Hello.
Try to raise your voice, Dr. Ratna. Your voice is too low.
Hello.
Yeah.
Mr. Adam William is diagnosed with Hodgkin's lymphoma, and my task force is to explain him the disease and the treatment plan, which includes chemotherapy and placement of Hickman line.
Okay, how do you think your scenario went?
I tried my best to convince, explain the disease and explain the treatment plan to Adam William, Mr. Adam William.
Okay, fair enough. What are the legal issues in this scenario?
The legal issues in this scenario is consent for the chemotherapy and Hickman line.
Okay, fair enough. What kind of consent for the chemotherapy in Hickman line?
It will be written consent.
Okay.
Written consent.
What are the criteria of the consent?
The criteria of the consent, the patient should be able to understand the investigations of the treatment plan.
Mhm.
And he should be able to reproduce it and
Do you know why the examiner asked you this question?
yeah.
Do you know why? Okay, fair enough. What are the ethical issues? Any other legal issues before the ethical?
But it's a serious illness. We should ask any advance directive.
This will kill your clinical judgment. Okay, so I'm going to be really tough, Dr. Ratna. You know you are my sister, but I'm going to be really tough. So what are the ethical issues?
Ethical issue autonomy. Here, Mr. Adam Williams has the full right to know regarding his condition, and he can accept or refuse.
Just a few seconds, Dr. Ratna, let me mute. Yes, continue, please.
Then beneficence, diagnosing the Hodgkin's lymphoma and starting chemotherapy and putting Hickman lines is beneficence for Mr. Adam Williams. And non-maleficence is preventing the side effects, detecting and preventing side effects of chemotherapy. And
okay, no. Try to apply the non-maleficence in different way. So the side effects, it's not one of the non-maleficence things. So to how to apply the non-maleficence here in your scenario?
To prevent any, while placing Hickman line, prevent any.
How to prevent the malplacement, Dr. Ratna? This is a complication. Would you be able to prevent in every possible complication?
No, but we'll be.
So
to detect,
what's the definition of non-maleficence, Dr. Ratna?
Do not do any harm to the patient.
Okay, avoid harming the patient. How to avoid harm him? He's someone who has lymphoma, first of all. He's going to receive chemotherapy. This is the second thing. He's going to have a Hickman line. So lymphoma and chemotherapy will make him prone for any infection. The Hickman line will be prone for any trauma. He's someone working in a kindergarten with the children. The source of the infection, the source of haphazard movement and trauma. Have you told him that he has to stop working with the children for the time being?
Yes, no, ma'am, I didn't tell.
So this is non-maleficence here. Avoiding harm for Mr. William. How to avoid harm? By avoid his current occupation, because his current occupation will make him prone for the infection, and he's already susceptible for that, will make him prone for any trauma for his Hickman line. Am I right?
Yes, ma'am. Yes.
Oh, finally, your voice is good now. So
Sorry.
this is the non-maleficence, and this is how to apply that. Okay?
Yes, ma'am. Yes, ma'am.
Okay, so let's then comment. And I'm really sorry in advance. I'm going to be really tough because I know your level and I know that you can do better than this. First of all, I'm really sorry to tell you, Dr. Ratna, that your clinical communication skill, it's not the communication station, communication skill, one of the skills would be lost in this scenario. Why? You've mentioned two jargons. Hello, I'm Dr. Ratna. I'm the doctor in the oncology clinic today. You've started your scenario with a jargon, Dr. Ratna, which is something really bad. Well, shall I mention, hello, I'm Dr. Al Hashmi, I'm the doctor in the cancer clinic today. Absolutely no. Do not start with the cancer clinic. Do not mention oncology because oncology is a jargon. So how to introduce myself? Hello, I'm Dr. Al Hashmi. I'm the doctor in the clinic today. Do not specify. So oncology, your first jargon, prognosis, your second jargon. You've mentioned two jargons. Okay? Then after that, you've introduced yourself and you've asked the patient about the ID, about his background and expectation, which is really good. And he told you, doctor, I'm afraid from the new variant of COVID-19. You've explained it's not a COVID infection, which is perfect. So you've answered the first concern. So I'm sorry to tell you that you have been diagnosed with a condition called Hodgkin lymphoma. This is how we introduce or how we counsel on any new diagnosis. Hodgkin lymphoma, have you ever heard about it? No, doctor, what is it? So let me draw you a drawing. Before explaining this is a cancer, explain the physiology, Dr. Rahma. So this is your body, and in every side of your body, you've got some nodes which is responsible to defend your body against certain infections. I'm sorry to tell you that these nodes affected by some growth, which is cancer. I'm sorry to tell you that. Oh, doctor, this is really bad. Are you sure? How to answer, are you sure, Dr. Ratna? You've told him, I'm sure. So, in a very rude way, like, I'm sure, shut up. It's not like this, Dr. Ratna. So, if the surrogate asked you, are you sure about the diagnosis? How to answer him?
I really appreciate concern, Mr. Adam William. I'm sorry
I'm
to say.
going to come to appreciate because you've mentioned, I really appreciate 4 times, which is not acceptable. You have to use a variant of vocabularies. Oh, thank you for sharing your thoughts with me. It's a really good question. So do not appreciate all the time, Dr. Rahman. Are you sure? So thank you for sharing your thoughts with me. Then
I'm sorry to say this. I'm sorry to say this, but you're having Hodgkin's lymphoma.
he didn't ask you, what do I have, doctor? He asked you, are you sure? I'm sorry to tell you, Mr. William, that the management team double-checked your result. So we are sure. It's not I am sure, it's we are. Okay? And why we are sure? Because we've double-checked your results. Okay? So then, after that, you've told him about the lymphoma, which is a kind of cancer. Doctor, are you sure? How to continue counseling on a new diagnosis? Counseling on a new diagnosis equal, mention the name, Hodgkin lymphoma, then physiology. This is a kind of nodes. Then the pathology. This is a kind of cancer. Then after that, the signs and symptoms and complication. Signs and symptoms typical to your presentation. You don't have to mention too many signs and symptoms, just typical to your presentation. Complication varies from only lumps and bumps and fever, reaching up spread of this kind of cancer into other organs. Have you mentioned that?
The complications I didn't, ma'am.
Okay. So missing the complication will affect your clinical judgment skill.
Yes, ma'am.
After that, he asked you, doctor, am I dying? How to answer this? You didn't answer this concern at all, Dr. Rat. How to answer, am I dying? Any specific structure, Dr. Rat?
Ma'am, first address his concern, then say the negative.
Yes, so the
thought,
communication game.
Yes, ma'am.
What's the communication game? Appreciate his question and then give him the piece of the truth plus reassure. How to do that? So the negative ID and the positive ID. How to do that? Am I dying? I'm sorry for your feeling. So despite this is a kind of cancer, but it has a very, very good outlook. Especially the patient got lymphoma grade 2A. So there is a curance rate for more than 75%. So simply, you don't have to mention any numbers because we've agreed that there is no numbers in station 4. So how to answer him, doctor, am I dying? I'm sorry for your feeling, despite this is a kind of cancer, but got a very good outcome. Then reassure, we are here to support you and to support you by giving you the best management. So this is how to answer him. You didn't answer that. What you've told him, Dr. Ratna, the consultant decide. Shall we mention anyone by name, Dr. Ratna?
No, ma'am, it's a team.
So it's a team, it's not the consultant. So the management team decide to start you on medication. And then start your second step, which is the counseling on a new medication. And before the management plan, we have to take the history, and you've taken the history, but you didn't apply that. Your patient working in a kindergarten, you didn't apply that. You've started asking further questions about his financial support and so on. I think this is a long scenario and you don't have time for that. You have to be targeted. Any medication, especially blood thinning medication, because you are going to insert Hickman line. This is the first question. Do you smoke? Do you drink? Because it's a routine questions. The third question, what do you do for living? And with whom do you live? That's it. Okay? Plus minus asking about his future family planning. You can ask about this. However, if you didn't ask, the patient will raise the concern. Okay? So, after asking the questions, tell him about the medication. So, the medication, it's a kind of chemotherapy, which is anti-cancer medication, will destroy the cancer cells. So, first of all, define the medication. After definition of the medication, tell him the route of administration. Most probably will be through your IV channels or your blood channels. Okay? Then, after mentioning that, you have to mention the side effects. Do not let the patient ask you about them. So, like any medications, chemotherapy carry a risk of side effects, which is varies from only sickness and throwing up. So you've mentioned that the chemotherapy will affect the gut lining that can lead to loose bowel, like you are explaining in physiology lecture. And you are dealing with someone who's really simple, gentleman who's working in a kindergarten. You didn't mention the nausea and the vomiting, which is the commonest side effect for the chemotherapy. Did you get that, Dr. Ratna?
Yes, ma'am. Yes, ma'am.
So varies from very simple side effects like sickness and throwing up, reaching up to serious side effects like very serious kind of infections. But be sure we will give you the treatment in controlled doses and regular follow-up. As simple as that. Am I going to lose my hair? This is one of the side effects. No, doctor, I will never take it. Be sure that the benefit outweigh the risk. And we are here to support you. Okay? Then he told you, doctor, is it curable? So you've told him if we pick up this diagnosis early, you've got the grade, Dr. Ratna. And still you are hesitant answering his question. Am I right?
Yes, ma'am.
Okay, which is absolutely wrong. After mentioning the chemotherapy, like any counseling on a new medication, which is the definition of the chemotherapy, the route of administration, if there is any specific like consideration here, there is no specific consideration, then the side effects, then you've told him because the chemotherapy has to be given throughout your blood channels, we will insert line into your blood channels. He told you, doctor, previously I've got an antibiotic throughout my blood channels and nobody explained all of these things. You've told him this is not the regular channels. What do you mean by not the regular channels? Have you mentioned that you have to insert the Hickman line in the biggest or one of the bigger blood channels? Have you mentioned that it could be in your neck on upper chest?
No, ma'am, I didn't mention.
So he didn't get anything from your side regarding the Hickman line. Okay, so your clinical communication skill would be affected. So how to explain the Hickman line? So because we need to give you the chemotherapy throughout a big blood channels to avoid any irritation, we have to insert some tube called Hickman line. Would you like me to explain further? Yes, please, doctor. So we would like to insert this throughout your big blood channels, either in the upper chest or in your neck. This procedure will be done by expert team who did this procedure several times previously. Before the procedure, we will make sure that you are fit for the procedure. During the procedure, we will clean the skin, we will numb the area, we will introduce some needles and wires, most of the times under imaging guidance, and just to be sure that this tube or this line will be inserted in your big blood channels and everything will be fixed just under your skin. It's going to be easier to administrate the chemotherapy after it. After that, we will keep you for a while just to be sure that you will not suffer any complication. Oh, doctor, what kind of complication? Mention the complication before mentioning the consent, doctor. Okay, complication varies from very simple complication like pain up to introduction of infection, bleeding, injury to the adjacent organs, because one of the complications would be pneumothorax. Okay, so mentioning all of these things, doctor, I'm afraid, be sure that all of these complications minimal with expert hands. After discharge, if you've developed any intractable pain over the site of the procedure, any bleeding, any raised body temperature, please be sure that you are going to seek medical advice as early as possible. If you didn't mention that, you've lost the safety netting for your patient. Okay? After mentioning all of these things, tell him about the consent. So, what you are going to mention within the consent. Do you know why the examiner asked you about the criteria of the consent? Because you didn't mention that for your patient. So, Mr. William, before having this procedure done, we need you to sign a consent. This consent will contain all the information that we've discussed. So we'll inform it. The patient has to be well informed. Read it carefully and sign it when you feel ready. So the patient has to be volunteering. No pressure exerted on him to accept the procedure. Then be sure that you've got the right to withdraw your consent at any time before the procedure. So non-continuous consent. So the criteria of the consent: competent patient, well-informed, volunteered, and non-continuous consent. So how to avoid the examiner question? Telling the patient before having this procedure done, we need you to sign a consent. This consent will contain all the information that we've discussed. Read it carefully, sign it when you feel ready, and be sure that you can withdraw this consent at any time before the procedure. Did you get that, Dr. Ratna?
Yes, ma'am.
Okay, when he asked you why, doctor, it's not like normal, like antibiotic, you've told him this is repeated cycles, regular channels. So you were not clear at all for him. Okay? Then the examiner's question: doctor, what's your scenario about? So simply, my scenario about breaking bad news, which is diagnosis of lymphoma, counseling on medication and procedure. Medication, chemotherapy, you don't have the exact name of the chemotherapy or the regimen that he's going to receive, plus the procedure, which is the Heckman line. How do you think your scenario went? I've tried my best. Okay, so after that, sorry, just before the examiner's question, the patient's concern. Doctor, do you think that I'm going to lose my ability to have children in the future? You've done something brilliant by raising the sperm banking. However, what you have to tell him, you have to explain this is a concern. So the exact regimen of the chemotherapy, it's not decided yet. Okay, so this is the first thing. Some chemotherapies can affect your ability to have kids. However, it's going to be a reversible side effect. Just to be sure, you can use the sperm banking to freeze your sperms if you'd like to have children in the future.
Okay.
Is it clear?
Yes, ma'am.
So the examiner asked you, doctor, what are the legal issues in this scenario? So you've mentioned the consent. Perfect. Any other legal issues? We have fixed legal issues, Dr. Ratna. Do you remember the fixed legal issues?
The confidentiality?
Of course. Why you didn't mention that?
Okay, ma'am.
And the capacity.
Okay.
So the confidentiality and the capacity. So both of them, legal issues. What about the ethical issues? The examiner asked you about the ethical issues to apply them. To tell you, doctor, you didn't apply non-malfeasance. You didn't tell him that you have to stop your job. Did you get that, Dr. Adnan?
Yes, ma'am.
So this is the general idea, and this is my comment. And I know that I was really tough, but you know, Dr. Ratna, just because I know your level, I'm not going to miss any point.
Yes, ma'am. Yes, ma'am.
Okay? Do you have any question within your case?
No, ma'am.
Oh, okay. So you're welcome. Let's wrap up the case first. So this is a case, so please mute, guys. So this is a case of lymphoma counseling, how to approach such case, starting with introduction, breaking the bad news, explaining this is a normal physiology. Explain the normal physiology, which is the meaning of the lymph node, definition of the disease, cause, if there is any specific cause, signs and symptoms, supported by investigation, plus the complication. Then the social history in details, especially the occupation of the patient, because most of the times would be like there is a direct implication on his occupation, plus minus the family planning. Even if you didn't ask about the family planning, the patient will ask you. Explaining the management plan in detail. So the management plan will include the chemotherapy first, then the Heckman line, then follow up, then the alarming signs. If there is any precautions, the precautions here, avoid dealing with cats. Then the consent and recap and closure if you've got time, and check the understanding. I've got another comment, which is that you've summarized your scenario, Dr. Ratna. So please, Dr. Tashnu, mute your mic. Okay, so Dr. Ratna, you've summarized. Let me mute that, sorry. So please, guys, mute your mics. So, okay, so you've summarized the scenario, and we've agreed in station 4, there is no point of summary. You are going just to lose your time by telling the patient, let me summarize my own speech. I'm telling you all the story all the time, and I'm going to summarize my own speech now again, like you are mentally retarded. So do not summarize your own speech. We've agreed for what you are doing. In station 4, your flow from your side toward the patient. So no need to summarize your own speech. But the most important thing is to check the patient's understanding. How much did he get from your discussion? It's against station 2, where the flow of the information from the patients toward you all the time. So the patient giving you the information. I've got headache, I've got numbness, I've got red eye, I've got vomiting, I've got diarrhea, I've got abdominal pain. So the patient telling you stories all the time. At the end, you would like to be sure that you've gathered all the possible information from him by summarizing that. So Mr. David, I'd like to summarize what I've got from your discussion. So what you've got, summarize it. But in station 4, you are giving the information. Just summarize what he has got from your discussion. Did you get my point, Dr. Ab?
Yes, ma'am. Yes, ma'am.
Okay, great. So what could be the possible concerns here? Is it curable, doctor? So is it curable, doctor? We've got a game by answering this. Am I dying? Is it curable? Am I going to be okay? And so on. We've got a game. What's our game? Our game would be appreciate that. Thank you for sharing your thoughts with me. I'm really sorry for your feeling. Oh, this is a really good question. So appreciate his question by any way, apart from saying appreciate your question too many times. Then the second point would be just telling him the piece of the truth, the real medicine. The real medicine telling us, despite this is a cancer, but this kind of cancer have really good outlook. Okay, so this is the real medicine. Then after that, reassure. How to reassure the patient? All the time tell the patient, we are here to support you and giving you the best management. So this is the answer of, is it curable or am I dying or so on. So thank you for sharing your thoughts. Despite this is a kind of cancer, but most of the times, especially in this stage, got a very good outlook, and it could be curable, yes, and be sure we are going to support you throughout your journey. Why not needle in my arm, doctor? Why you've chosen to give me a Heckman line? You didn't tell him where you are going to insert the Heckman line. That's why the patient didn't ask this concern. Why it's not needle in my arm? Simply, it's not needle in your arm because needle in your arm, it could be problematic. It could give you a kind of irritation. That's why we need to give you the chemotherapy in big channels. It could be out for many times and we need to puncture you for many times. Then it could lead to serious complication, leading to even amputation. That's why it's not needle in your arm. I'm afraid that the chemotherapy will affect my ability to have children in the future. Well, we don't know the exact regimen yet. However, some chemotherapies may affect your ability to have children, but it's going to be transient side effect and reversible. However, we can offer you sperm banking just to be sure or in the safe side. Am I going to lose my hair? This is one of the side effects. Try to reassure him that the benefit outweigh the risk. And apart from the benefit and the risk, you are going to support him. You are going to follow up him just to be sure that you are going to control the complication as early as possible. So this is the possible concerns, Dr. Ratna. Do you have any question, Dr. Ratna?
No, ma'am. Thank you.
Okay, thank you. So, perfect. So let's open the door for the questions then. Do you have any question, guys?
Yes, Dr. Ala. Assalamu alaikum.
Wa alaikum salam, Dr. Muna.
I just want to ask, because you said when I introduced myself, because the written clearly you are the doctor in the oncology department. So
Yes.
I don't know how I will know if the patient he knows he has the appointment in the oncology department, or maybe if I did not mention, they will consider this as a negative mark. I did not show myself as the scenario written.
Yes. So this is a really, really good point, Dr. Muna. So first of all, from the scenario, once you are reading your scenario, you will know whether this is a first visit or this is a follow-up visit. So first visit means that you are going to counsel your patient on a new diagnosis. If you are in the gut clinic, you can mention that. If you are in the respiratory clinic, you can mention that. If you are in the CNS clinic, you can mention that. But the oncology, it's completely different, because from our regulation in the station 4, for the oncology patient, you have to break the bad news into steps. So you have to break this into small pieces. Do not tell the patient since the beginning, hello, I'm Dr. Ala Hashmi, I'm the doctor in the cancer clinic. So before telling him anything, you've mentioned, I'm a cancer doctor and you've got a cancer. Did you get my point, Dr. Muna?
Yes, Dr. Ala. Yes, I got it.
So,
very clear.
The point is how to mention that before telling him I'm the doctor in the cancer clinic, and like avoiding telling him I'm the doctor in the cancer clinic. At the same time, I'm not going to give the impression to the examiner that I don't know how to introduce myself. Hello, I'm Dr. Ala Hashmi. I'm the doctor in the clinic today. As simple as that. Did you get that, Dr. Muna?
Yes, it is clear. Thank you.
Oh, okay, perfect. You're welcome. Any other question?
Doctor?
Yes, ma'am. One
Yes,
last
Dr.
question.
Marwa?
Doctor, here I ask a patient about advanced directive as the disease has high cure rates. I ask him also.
Absolutely no. When Dr. Ratna mentioned that, I've told her that you are going to kill your clinical judgment. So within the lymphoma cases, never ever raise the end of life issues. Is it clear, Dr. Marwa?
Yes, doctor. Thank you.
You're welcome.
Ma'am,
Yep.
just want to confirm that hair loss and infertility, they are reversible or not?
Yeah, absolutely, yes. What do you think, Dr. Shaheen?
Ma'am, I read that it is irreversible, infertility. Hair loss is reversible.
So the infertility, most of the chemotherapy will give the patient reversible infertility.
Okay, ma'am. Just thank you, ma'am. Thank you, ma'am.
You're welcome. Any other question?
Yes, Doctora, please.
Yes, Doctor, say.
Is it good impression for the patient to tell him that your plan of treatment is not decided yet, and we wanted to introduce this Hickman line in your body?
So It's not your plan not decided. You've decided to give him a chemotherapy. This is a must. And for the chemotherapy, any regimen, you have to insert the Hikma line. But the exact regimen not being decided yet. Because if they told you within the scenario that the oncologist decided to start him on CHOPS regimen, as a candidate, Dr. Sayed, you have to explain the CHOPS regimen. And they know in PACES this is a subspecialty. They will never bother you explaining a specific type of chemotherapy.
Okay.
Did you get that, Dr. Sayed?
Yes, yes.
So the exact regimen, it's not the plan made already. So the plan, he will start with the chemotherapy. We have to insert the Hickman line. But the exact regimen, not decided yet. Exactly, if someone who presented, let's say with, he presented with rheumatoid arthritis. So you are going to start one of the disease-modified drugs, definitely. But you don't know which one you would like to start him on because the management team didn't decide yet whether you are going to start him on methotrexate, on gold, on penicillamine. You don't know yet. Did you get that, Dr. Said?
Yes, thank you. Thank you.
You're welcome.
So, ma'am, if the medicine is not mentioned in the case, the examiner can ask in why were the side effects of job regimen like that.
Not mentioned or mentioned?
No, if it is not mentioned,
not
job
mentioned, no one will ask you about detailed side effects. You have to know the common side effects. All the chemotherapies, sharing, nausea, vomiting, possibility of hair loss, possibility of infertility.
infections.
Yep.
Okay.
You're welcome. Any other question? Yes, Dr. Kumar.
Why not needle in my arm? You said irritation, repeated puncturing, and what was the third one?
Okay, it could be problematic. So if this chemotherapy goes out your blood channels, may lead to death of the tissues and even amputation of your arm.
Okay, thank you.
You're welcome. Any other question? Okay, great. So let's move to the next case and let me check. I think it's going to be Dr. Anuba. Dr. Anuba, are you here?
Yes, ma'am.
Okay, great. So, Dr. Anuba, this is your case and it's a station 5 case. You will have 2 minutes to prepare your thoughts and go. And others, please mute your mics.
All right. patient is a male? Or
Yes. Mr. Adam. So he's a male. Okay, time up. Are you ready?
yes, ma'am.
And go.
Hello, I'm Dr. Hinduja. I'm the doctor in the emergency department. Is this Mr. Adam Johns? 50-year-old
Yes,
male?
doctor. Yes,
Alright.
I am.
Can you tell me what brings you here today?
Well, doctor, I have experiencing recently attacks of loss of consciousness.
All right. Can you tell me how many times it has happened before?
3 times, doctor.
Okay. And were all the 3 events similar?
I believe so, yes.
Okay. So, can you tell me that when did these loss of consciousness happen?
Well, doctor, one of them used to be yesterday, the other one a week ago, and the first one happened 10 days ago.
I see. And was there anything that led to these episodes?
What do you mean, doctor?
Do you think that was any common factor that triggered these episodes?
No, not really.
Okay. And before you lost consciousness, did you have any unusual feeling or any feeling that you're going to faint or anything?
Yes, doctor. I feel like I've got a kind of chest discomfort before that.
Any racing pacing of your heart?
No, not really.
Can you describe the chest discomfort further?
So this is a kind of chest discomfort. It's not a real pain, doctor. It's just chest discomfort.
Does it increase with increase in breathing?
No.
Okay. And you said there's no chest pain nor any racing pacing of the heart. And
So I told you that there is no chest pain before losing my consciousness, but generally, recently I've experienced chest pain, doctor.
okay. Can you tell me where is the chest pain located?
It's in the center of my chest, doctor.
Okay. And does it move anywhere? Does it move to any other parts of your chest?
No, not really, doctor.
Okay. And whenever you have lost consciousness, have you noticed any kind of involuntary movements?
No, doctor.
Okay. And how severe is the chest pain? Can you describe it on a scale of 1 to 10?
Well, doctor, when I've got this chest pain, I will give it a score of 8 over 10.
Okay. All right. And do you have any sweating associated with this chest pain?
Yes, doctor, sometimes.
Okay. And it is only after this chest pain that you lose consciousness?
No, doctor. I've told you chest pain, it's not related to losing my consciousness. I've told you before the losing the consciousness, I've got chest discomfort. It's not a pain. It's not the same.
Okay. All right. And have you noticed anything that triggers the chest pain?
Like
Any
what, doctor?
exercise or any exertion?
Yeah, I think it's more after doing any kind of exercise, doctor.
Okay. All right. And have you noticed that it comes down if you're resting?
No, not really.
Anything else that you notice relieves the chest pain?
So, yes, doctor, a kind of just being relaxed, my chest pain will gone.
Okay. And have you noticed that you notice any tingling numbness in your hands or your jaw?
No.
Any kind of numbness? Okay. And when you lose the consciousness, have you noticed after you regain consciousness, are you aware of the events or are you not aware about the events?
No, I'm aware.
Okay. And nobody has anybody noticed any involuntary movements during the loss of consciousness?
No.
Any loss of water work or bowel work during the loss of consciousness?
Yes, doctor. I wet myself twice.
All right. Okay. And have you been noticing any kind of memory issues?
No.
Okay. If it's okay, I would like to examine you along with question you. Is that okay?
Yes, sure, doctor.
Okay. Can I have a look at your hands? I want to check for clubbing.
Okay. No clubbing.
Or any kind of nail changes like sphincter hemorrhages or anything.
No, nothing. 2 minutes remaining.
I would like to examine the eyes for pallor.
No pallor.
Okay, I would like to examine the chest of the patient, and I would request him to remove his clothing.
Okay. So, would you like to examine the chest or pericardium, do you mean?
The precordium.
Okay. What you would like to do for him?
I would like to check, localize the apex beat and then auscultate the heart sounds at the apex, the aortic area, as well as the pulmonary and tricuspid area.
Okay, first heart sound, second heart sound, ejection, systolic murmur.
And I would like to check the carotids for any bruit.
No bruit.
Okay, I would like to, where is the ejection systolic murmur in the
all
aortic
over
area
the
or-
pericardium, best heard over the aortic area.
Okay, okay. And this murmur doesn't go to the axilla.
No.
Okay. Mr. Adam, can you tell me what your concerns are?
What do I have, doctor? What's wrong with me?
Based on your history and examination, sir, it seems that you have a condition of the heart. It is related to something called as the valves, which is stationed between the two chambers of the heart. Your condition seems to be something called as aortic stenosis. Please don't mind the name. But it is the narrowing of this valve that causes these changes. And
Time up. Okay. So, doctor, what are the positive findings within your scenario?
The positive findings are that there's a ejection systolic murmur best heard at the aortic area.
Any other positive findings? So,
No.
Dr. Anuba, the positive findings mean history and examination, both.
Okay, all right. So the patient has a history of chest pain as well as syncope, and
Okay, fair enough.
and
What could be your... Yes. What
along
could
with
be...
this-
Yeah.
Sorry, ma'am. Go on.
Along what? Along what?
Along with this ejection systolic murmur.
Mm-hmm. So, what could be your differential diagnosis here?
Well, I would think of aortic stenosis since it is best heard at the aortic area. Well, a similar murmur can also happen in anemia, but this patient has no signs of pallor.
Mm-hmm. Okay. Any other
Also
differential?
like to rule out any kind of arrhythmia, although the patient denies any racing pacing of the heart.
Mm-hmm.
And the patient had water work loss during those episodes. So I would like to keep a CNS condition in mind, although history is not suggestive of it.
Okay. How would you investigate your patient?
I would firstly like to do electrocardiogram. I would like to do certain blood tests like complete blood count, creatinine level, electrolytes. I would like to order a 2D echo and to check for the valve functioning.
Okay, that's fine. So your first differential diagnosis would be syncope related to aortic stenosis. Am I right?
Yes, ma'am.
What could be the cause of his aortic stenosis?
It could be congenital, like bicuspid aortic valve, given the fact that he's 50 years of age. Unlikely to be degenerative because in that case we would expect an older patient.
Okay. Or 50 years old patient plus risk factors. Have you asked about the other risk factors? Do you think that he's a smoker?
I didn't. I ran out of time.
Okay. Any history of diabetes, hypertension, any medication use?
I didn't ask because I was short.
Okay, that's fine. So thank you, Dr. Anuba, for doing the case. And I'm really sorry in advance, and I'm going to be really tough. You are, as far as I remember, that this is the first time for you practicing with me. Am I right?
Yes, ma'am.
So I'm really sorry. Do not feel offended. It's not related to you. It's not related to my own approach. I'm a bit tough in commenting on every single point, just to seek the perfection here. Okay?
Yes,
so I know that the previous candidate, Dr. Kamal, practiced with me many times, and she know my approach. Dr. Ratna as well, she's one of my sisters, and she practiced with me a lot, and she know my approach. And Dr. Shaheen, after you, she knows my approach as well. But just apology in advance, I'm going to be really tough.
All right, no problem.
So first of all, there is no justification called I don't have time for it. Okay? You don't have time equal you are not organized. This is the first thing. The second thing, you've done something really irritative for the examiner. So you've asked one question related to the loss of consciousness, the second question related to the chest pain, the third question related to the loss of consciousness, the fourth question related to the chest pain. So you were asking alternative questions. The presenting complaint is the loss of consciousness. First of all, I don't feel that you've got a good differential diagnosis, and I'm going to tell you why. How to analyze loss of consciousness. Either you are dealing with a station 5 or you are dealing with a station 2. You have to classify the loss of consciousness into before, during, and after. Before, have you got any specific symptoms like headache, weakness, awareness of heart beating? Awareness, it's not racing, Dr. Anuba, because awareness sometimes means missed beat. So the patient will have loss of consciousness because of bradycardia. So any awareness, not equal racing. Any awareness of heart beating, any chest discomfort or chest pain, any hunger, pain, sweating, or shakiness of the hand. So this is before. Before, you have to ask about CNS related, CVS related, hypoglycemia related. You didn't exclude hypoglycemia in 50 years old gentleman, and you don't know whether he's diabetic or not. So this is before. Then during, any witnesses, any changing color. Why changing color? Because if the patient turned blue, means that you are dealing with a neurological event. Most likely this is a convulsion. If the patient turned pale, most probably you are dealing with cardiovascular event. Okay? Then anyone checked your blood sugar at that time? And then have you lost control on your back passage? Never ask about the urine. Why? Because anything can lead to urine incontinence, cardiovascular event, vasovagal attack, neurological event. So the urine incontinence will never give you a clue. But someone who lost the control on the back passage, 100% this is a neurological event. Did you get that so far, Dr. Anuba?
Yes, ma'am.
Okay, then after, so how long you remained lost your consciousness, or for how long you've lost your consciousness? If the patient told you almost 20 minutes, means definitely you are dealing with a neurological event. If the patient told you few seconds, maximum 2 minutes, this is a cardiovascular event. So this is after. How did you regain your consciousness each time? Well, my wife giving me sweetie things. So you are dealing with hypoglycemia. No, doctor, just I regained the consciousness by myself. My wife raised my legs. Most probably you are dealing with vasovagal attack. So how did you regain your consciousness? Then after that, do you have any weakness or headache? The post-ictal state. So this is how to analyze that. Rather than asking, have you noticed any abnormal movement? The patient will never notice that. Then you've asked the same question and noticed that you've got abnormal movement. So simply before, have you noticed any symptoms before losing your consciousness? Like, you have to give examples. Like, any headache, any weakness? No, doctor. Any awareness of heart beating or any chest discomfort? No, doctor. Any hunger, pain, sweating, or shakiness of the hand? No, doctor. So I know that you are asking about each symptoms together, CNS, CVS, hypoglycemia. Anyone witnessed your loss of consciousness? Yes, my wife. Did she check your blood sugar at that time? No. Has she told you that you've got any specific color? She told me that I became really pale, doctor. Okay. Did she notice any abnormal movement or loss of control in your back passage? No, doctor. For how long? How did you regain any post-ictal state? Is it clear so far, Dr. Anuba?
Yes, ma'am.
Okay. So anyone presented with loss of consciousness, two things are must to ask about them. Drug history. Why? Because drug history could be the cause. If the patient diuretics, he may have hypotension because of the diuretics. That's why he lost his consciousness. If the patient using anything can lead to long QT syndrome, can give him loss of consciousness. If the patient using beta blocker or calcium channel blocker can lead to bradycardia. So the medication is a must here, and there is no justification that I don't have time. Then the family history, because the cause of loss of consciousness, it could be related to Hockham and his ejection fraction, his ejection systolic murmur, it could be related to Hockham as well. Am I right, Dr. Anuba?
Yes, ma'am.
So, and he told you that he's losing his consciousness related to exercise. And he told you that the chest pain related to exercise. So simply, it could be Hokum. Am I right?
Yes.
So drug history and family history is a must in any loss of consciousness case. Okay? Then, once you've started examining your patient, you have to start with the general examination. So you have a lock already over his hand, but you have to check his pulse. Doctor, I've got his pulse from the eye. It's 88, so most probably it's not Brady. You are absolutely right. But you have to check the regularity and the volume here is critical. Because if you are dealing with Hokum or aortic stenosis, most probably you will have small volume pulse. Am I right?
Yes.
Okay. Then you have to check the patient's JVB. Then go for his pericardium. Checking the apex beat localization, which is perfect. Then auscultating his pericardium. Okay? So, simply, you've got patient who has loss of consciousness and chest pain. Most probably his loss of consciousness cardiovascular related, and you've got ejection systolic murmur. What could be your diagnosis? It could be aortic stenosis. It could be Hokum. How to differentiate between both? Family history, and you didn't ask about his family. Am I right?
Yes.
Okay. So simply, this is a case of loss of consciousness. And sorry for that, our patient is George Clooney. So the differential diagnosis for loss of consciousness, it could be cardiac, could be neurological, and it could be reflexes. And I'm going to tell you how to think about reflexes. This case appeared, this died a few weeks ago here in London. And some candidate, they were thinking it's a reflex syncope, while the patient got aortic stenosis versus Hokum. So the cardiac could be structural or arrhythmia. What do you mean by structural? I mean outflow obstruction. What are the things can lead to outflow obstruction? Both aortic stenosis and Hokum, AS. Arrhythmia, it could be Hokum or lung QT. Both of them you have to ask about family history. Lung QT, you have to ask about medication. Then neurological, it could be epilepsy, TIA, and stroke. That's why you are asking before about any weakness, headache, and after about any post-ictal state. Reflexes, it could be vasovagal reflex. For the vasovagal, why it appeared? Okay, for the vasovagal reflex, the patient will give you the loss of consciousness after standing in a long queue or standing in for a long time. This is the classical presentation for vasovagal attack. I used to be in the supermarket for a long time. I used to be in a bank queue for a period of time. So most probably this is a vasovagal attack. Situational, which is just in terms of differential diagnosis, but will never be the diagnosis in basis. Situational, the patient will have loss of consciousness after Valsalva maneuver, either after coughing, after sneezing, or after defecation. Carotid hypersensitivity, for the sake of the differential diagnosis, they love carotid hypersensitivity in MCQs, but will never be the diagnosis in PACES. Carotid hypersensitivity, someone who's wearing tight shirt or tight tie, but will never be the case in PACES. Then you have to think about the emergency. Things like hypoglycemia, hypotension. Hypotension PACES-wise Most probably you are dealing with diuretics. So appeared previously someone using diuretics, increased dose recently and presented with loss of consciousness, which is hypotension related. And it could be anemia, which is extremely unlikely. So this is the differential diagnosis for loss of consciousness. You will have time once you are organizing your thoughts, before, during, after. After that, ask about family history, drug history, go directly for the examination, examine the patient, finish the social part. Here, for this scenario, your clinical judgment would be severely affected. Why? Because you've got patient with loss of consciousness, you don't know his occupation. He's working as a bus driver. So he's going to kill himself and he's going to kill the passengers. So having time for social history is a must. Did you get that, Dr. Anuba?
Yes.
Okay. Do you have any question within your case? Okay, great. Any question, guys?
Actually, madam, this in Hukum, is it possible to differentiate that pulse character or
Between Hukum and aortic stenosis?
yes?
So it's going to be unlikely to differentiate only by pulse character, but the main difference would be the character of the apex speed, Dr. Hamad. The apex speed in the aortic stenosis would be tabbing, but in Hukum would be double apex speed impulse.
Okay, thank you.
You're welcome.
Hokum at this age?
Madam, I have one question.
Hello? Yes, Dr.
Yeah.
Ben. Yes, please.
Ma'am, when we will understand asking some question that it's a syncope, not seizure. So
Yes.
We should only ask about the syncope question, right? And when we find the findings like the ejection systolic murmur in the precordium area, so should we ask about other question like orthostatic, because we are short of time and we have to take the whole social history, drinking history, and smoking history also as well. So should we just channel to that area, just ignore the other orthostatic hypotension or neurocardiogenic syncope, and should we just ignore those states?
So this is absolutely fine. Once you've excluded, it's not a vasovagal syncope. You can skip the situational and carotid hypersensitivity like this. You can skip them, and you can have the full mark. But you will never be able to skip ischemia and hypertension, especially diuretics related. And once you've got it's cardiovascular related, you are not going to ask any neurological question. And by the way, 100%, it's not 100%, a 200 over 100% of the cases of loss of consciousness will never be neurological impasses.
Okay, thank you, ma'am.
You're welcome. Dr. Sabah, would you please repeat your question? You've got interrupted connection.
Dr. Ala?
Yep.
The age is 50-year-old, so shall we consider Hokum at this age?
Yes, absolutely. Any other question?
Why the patient will look bluish in case of neurological? Because as far as I remember,
in case of convulsion, Dr. Dot.
But bluish discoloration is mostly due to cyanosis. Isn't that due to cardiovascular cause?
No. So the cyanosis that appear due to neurological loss of consciousness or the convulsion, the patient will have cyanosis during the convulsion, no doubt. That's why the patient will turn blue. But the patient within the cardiovascular causes of loss of consciousness, the patient will have decrease in his stroke volume. Once the cardiac output less, the patient will become pale. You are not dealing with cyanotic heart diseases leading to loss of consciousness, doctor. Do you get that?
Yes, thank you.
Hello,
You're
ma'am.
welcome.
Hello.
Yes, Dr. Huda.
Yes, we can admit this patient or not, since he has a severe aortic stenosis.
This is a great question, Dr. Huda. And let me continue the examiner's question with Dr. Anuba now. Dr. Anuba, how would you investigate your patient? You've mentioned ECG first, and I don't know what you've mentioned later on.
I mentioned a 2D echo to check for any structural heart disease, and
Perfect.
I asked for a complete blood count.
Okay, great. So how would you treat your patient giving your differential?
Treatment would depend on the diagnosis and
Let's
the
imagine that
evidence
your
I-
patient got aortic stenosis.
So since the patient is symptomatic, irrespective of the gradient, I would have to refer this patient to a cardiologist.
You are the cardiologist, Dr. Anuba.
Okay, so I would like to consider this patient for an intervention, either aortic valve replacement or a TAVI. Before that,
Perfect.
A CAG should be done in case if there is a coexisting atherosclerotic disease. Then the procedure can be decided accordingly.
Okay, perfect. So the main management would be surgical management. So how would you investigate your patient? Simply, I'm going to start with echo to confirm my finding. ECG, it could be Holter ECG, basic investigation, including full blood count and so on. How would you treat your patient? If the patient got aortic stenosis, the mainstay of treatment would be surgical intervention, either valve replacement or TAVI, valve implantation, or if the patient got coronary artery disease as well, he may benefit from other procedures, either PCI or CABG. Okay, so this is how to mention that. Would you admit your patient if the patient got aortic stenosis and the mainstay like treatment would be a surgical intervention? Admission would be a wise option, but it depending upon the echo finding. So what I'm going to do, urgent tests for him, including echo and ECG, and according to the tests, I'm going to decide whether I will admit him or not. Is it clear, Dr. Huda now?
Yes, doctor. So, doctor, for this driving issue, we should tell him to stop the driving?
Yeah, absolutely, yes.
Okay. And to inform the DVLA?
Yes, sure.
Okay. Thank you, doctor.
You're
Thank
welcome. You're welcome. Any other question?
Yes, madam. This is aortic stenosis is because of sclerosis. Here, cause of aortic stenosis in this 50 year.
We don't know whether the patient got bicuspid valve, whether the patient got degenerative one, because we don't know about his past medical history. If he's a smoker, has diabetes, hypertension, hyperlipidemia, poorly controlled, yes, it could be degenerative in 50 years old.
Okay, thank you.
You're welcome. Any other question? Okay, great. So let's move to the next case.
Ma'am, assalamu alaikum.
Wa alaikum salam, Dr. Kabir.
What do we mean by urgent in this case?
Sorry?
I mean 24 hours or 7 days or something urgently, because we have to take decision whether to admit him or not. We have to do the investigation urgently means within 24 hours or
I mean,
What?
urgently, do not send him home before the investigation. He has to be in the observation till the investigation will be done and the decision of the admission or sending him home would be made. Is this your question, Dr. Kabir?
Yes, yes. Whether to let him go or put him.
Yeah. Yeah. Hopefully, this is answering your question.
Yes.
Okay, thank you. So let's move to the next case. And Dr. Shaheen, are you here?
Yes, ma'am.
So this is your case, Dr. Shaheen. And again, it's a station 5 case, sorry. Yes. It's clear now. So you will have 2 minutes to prepare your thoughts and go. And this case appeared 2 weeks ago as well in London. Okay, time up. Are you ready? Would you please raise your voice?
Okay, ma'am.
Okay, great. And go.
Hello, good evening.
Good evening.
I'm Dr. Beg, one of the doctors in the clinic. May I confirm you are Mrs. Jones, 33 years old?
Yes, doctor.
I'm here to talk about your medical problem and I will examine you. Is that all right?
Yes, sure, doctor.
So you came with complaint of chest pain. Can you please tell me more about it?
Yes, doctor. I have noticed this chest pain last night, and this is really annoying, doctor.
Is this first time you had this or before also?
No, this is the first time, doctor.
Okay. Where exactly in the chest you have this pain?
Sorry?
Where exactly in the chest you have the pain?
Over the right side, doctor, of my chest.
Okay. If you grade from 0 to 10, 0 is less and 10 maximum, how is the intensity?
Well, I think it's around 6, doctor.
Okay. I'm sorry to hear that and we will help you. Is this
Thank you.
Is this radiating anywhere? Like
No.
or neck or jaw? Okay.
No.
Anything making it worse, like aggravating, like exercise or heavy lifting or walking?
No, not really, doctor.
Okay. Anything
I didn't try any exercise or heavy walking since last night, doctor. I didn't try that.
And anything painkillers? Anything you took to relieve it?
Yeah, I've tried paracetamol. I've tried codeine, but doesn't seem to help, doctor.
Okay. So you said you have chest pain. Any other problem you have, like cough?
No.
Any shortness of breath?
Yes, doctor. I used to use the stairs now just to reach your clinic. I feel like I'm short of breath.
And you have this since last night, right?
Yeah, doctor.
Okay. Do you feel more breathless at night?
Well, no, not really, doctor.
Like lying down making it worse?
Nope.
Okay. Do you feel any noisy chest?
Nope.
Okay. How many pillows you use at night?
I'm using only one, doctor.
Okay. Any leg swelling you noticed?
Nope.
Any awareness of your heartbeat?
Yes, doctor, I've got awareness.
Can you tap me and tell me how much fast or slow your heartbeat?
Yes, doctor, it's very fast and it's racing like this.
And it's regular?
Yes, doctor.
Okay. Okay, I'll ask some more questions. Any past history of long-standing illness I should be aware of?
No, doctor, I used to be very healthy.
Well, no blood pressure, high sugar, nothing like that.
No, not at all, doctor.
Okay. Any medicines recently you are started or taking in the past?
No, not really, doctor.
Well, any family history of note I should be aware of?
I don't know my parents, doctor. I'm adopted.
I'm sorry to know. Well, do you smoke, Mrs. John?
Yes, doctor.
How many cigarettes and for how long?
Almost 1 to 2 cigarettes a day for the past 2 years.
Mrs. John, smoking is dangerous for your health, and I would advise you to quit, and we can help you in this regard. Is that fine?
Thank you, doctor.
May I ask, what is your job, Mrs. John?
Well, doctor, I'm working as a secretary.
And this condition must be affecting you?
Yes, doctor, absolutely. I wouldn't be able to go to the company this morning just because of this pain.
We will help you in this regard. We have experts, social workers. Okay.
Thank you, doctor.
Do you drink alcohol?
Yes, doctor.
How many units, in a week?
I've never exceeded the permissible limit, doctor.
Okay, that's fine. I want to examine the patient now.
Yes, sure.
Check the pulse of the patient.
Okay, so the pulse is irregular. However, it's tachycardia like outside.
Okay, I want to check the nails. Any clubbing, anemia, jaundice?
No, nothing.
Okay, I want to check the JVP. Any raised JVP?
Nope.
Okay, I want to check the chest. I want to listen to the pericardium. Any apex beat first I want to see. Is it heaving or tapping?
No, apex beat and the left fifth intercostal space placed. There is no specific character.
Okay, I want to check the lungs sound, breath sound. Any creps?
Oh, no.
Okay, and I want to check the heart sounds. Any murmur of AS?
You have to be organized, Dr. Shaheen. You've started with the apex beat, complete with the heart. First heart sound, second heart sound, there is no murmur.
No murmur in the mitral area or aortic area, no murmur?
Nothing, no murmur.
The back of the patient, I want to check the creps and the breath sounds.
Okay, breath sounds equal bilateral and there is no added sound.
Okay, I want to check the carotids. Bruit.
Okay, there is no carotid bruit.
Okay, I want to check leg swelling.
Okay, no leg swelling.
And may I ask, what is your concerns?
Well, doctor, what's the cause? 2 minutes remaining. What's the cause of my chest pain, doctor? Please help me. It's really annoying.
Yes, Mrs. Jones, after examining, I have some possibilities. We will do some blood test and imaging of your chest, and we will form a multidisciplinary team. And what I think that you have some difficulty in the breathing, and it started last night. So there is a possibility of some. Okay, I will look into this. After investigation, we will form a diagnosis, and we can help.
Okay, doctor. Do you think it could be something serious?
Well, Mrs. John, there is a possibility that can be serious because it started suddenly. So it can be some maybe lung scarring or lung fibrosis or any lung expansion of the some of the cavities of the lung. It can be related to your vessels in the heart. So we will do some tests and we can make a diagnosis accordingly.
Okay, doctor.
Ma'am, in the chest, I want to see the any signs of a pneumothorax and chest expansion.
How to see that?
Well, breath sounds I will see if there are reduced
Breath sounds equally accepted bilaterally.
I want to check the eyes, any anemia, and I want to check mouth, any cyanosis.
No anemia, no cyanosis.
And JVP not raised.
JVP not raised.
Okay.
And time up. Okay. So, Dr. Shaheen, what are the positive findings within your scenario? And please, before answering my question, guys, seems that you forgot our regulation. We've got a very strict regulation. No any diagnosis, no helping in the chat box. I'm almost always saying the same. Wait and respect the candidate. You have to respect each other, guys. This is something like make me mad. Please do not say anything within the chat box. I'm giving the chance for everyone to practice. I'm almost always telling you the same. Anyone would like to practice, more than welcome. Just drop me a message or raise your hand within the free session. You are more than welcome to practice. And you have to respect the others like the others have to respect you during your practice. Sorry for the interruption, Dr. Shaheen. So, Dr. Shaheen, what could be the positive finding within this scenario?
Ma'am, this patient came with 1 day history of chest pain, which was moderate, and he has tachycardia. And on examination, I just found the tachycardia. There was tachycardia positive. So I think one possibility is pulmonary embolism.
Okay, have you mentioned that for her?
So, I just realized at the end that it can be a possibility. I should ask travel history also, which I forgot.
Okay, that's fine. What could be the other differential diagnosis for her?
It can be pneumothorax.
Okay, pneumothorax. How to exclude that from the history or the examination?
Then chest expansion will be reduced and breath sound will be decreased.
Do you think that this is the most accurate thing, the chest expansion and the breath sounds for the pneumothorax?
And pneumothorax.
Okay.
It can be raised.
So within your practice, Dr. Shaheen, within your own clinical practice inside the hospital, how would you detect the pneumothorax apart from imaging?
Then clinically, the patient will be dyspneic, and when we do, it is a clinical diagnosis, and X-ray will show.
What do you mean by clinical diagnosis?
And chest X-ray, between the two pleura, the increase in the volume, it will be more than 1 centimeter. If it is more than 2, we can drain it.
So, Dr. Shaheen, this is a question which is rarely common in PACES. How would you detect a pneumothorax? Simply by percussion. So, the chest expansion, it's not accurate, especially if the patient got bilateral pneumothorax. The air entry will never be accurate because it's subjective if the patient got bilateral pathology. But the percussion absolutely has to be the patient got unilateral or bilateral pneumothorax.
Right.
Okay, so percussion of the ABCs is the must. By the way, this case appeared 2 weeks ago here in London, and this case was my own case and my own exam. Okay, so The patient presented with sudden chest pain, shortness of breath, tachycardia. So most probably we are dealing with PE. And I'm going to tell you how to think about chest pain in general. What could be your brain map? Like we've got a brain map for the back pain now. We've got a brain map for the loss of consciousness. We have to have a brain map for the chest pain as well. This is the first thing. You are thinking about PE. The point is, and I'm almost always telling the same, to know, do not let anyone assess your performance. To know whether you've done good in your case or not, you have to ask yourself 5 C's. If you fulfill the 5 C's, you've done brilliant in your scenario without any feedback. The first C is confirming the diagnosis. How to confirm the diagnosis if the patient got any specific thing within the the diagnosis, like what? Like tachycardia, like shortness of breath. However, it's not specific here. And excluding the other differential. The main differential diagnosis will give the patient chest pain, which is pleuritic in nature, and you have to ask about this. What's the nature? And you think that this chest pain increased with laughing or breathing or coughing? She will tell you yes. This is a pleuritic chest pain. Okay, so pleuritic chest pain, acute, giving the patient shortness of breath and tachycardia, could be PE, it could be pneumothorax. How to confirm your diagnosis? The main thing, auscultation and percussion. And even if you don't have time for the percussion, percuss only the ABCs. So go for the apex percussion. This is the first C, confirming. The second C, which is most of the time, this is the track that most of the candidates will lose during the examination. And after leaving the station, well, doctor, I've done really good. Doctor, I've reached the diagnosis. I've got this is a PE, but however, they give me only 12 over of 28. This is completely unfair exam. It's not unfair exam just because you've lost the second C. The second C is the cause. What could be the cause of this condition? Or what could be the trigger of this condition? Do you think that your lady, which is 33 years old, pregnant by any chance, Dr. Shaheen?
Yes.
Does she use any oral contraceptive medication?
I didn't have time.
No, do not justify with the time, guys. I've told you this case appeared two weeks ago here in London, and I know the candidate who did this case, and she managed to ask about all of these things, and it was my own case within my own exam, and to be honest, I managed to ask about all the thrombophilic risk factors. So it's not in terms of the time, it's in terms of organization and brain mapping. Once you've got a clear brain map, definitely you will have time to ask about it. Okay? So, simply, how to ask, do you have any history of miscarriages, whether the patient got antiphospholipid syndrome or not? Any history of blood clots previously? So, doctor, I've asked her about the past medical history, and she told you I used to be absolutely normal. But the patient will never tell you about DD 3 years ago, which is treated at that time. So it was something very transient. It's not a chronic illness to tell you about it. So you have to ask specifically. And when you've asked me to see her mouth, I was really happy. Oh, you are seeing the mouth. You've told me for cyanosis. Oh, I lost hope. So mouth for oral sores, whether the patient got Behçet disease or not. Did you get that, Dr. Shaheen? Hello, Dr. Shaheen?
Yes, ma'am. I'm hearing you.
Okay. So, Sammy, how can I know how to deal with a chest pain? Just from the outside, I'm going to give you some clue. Someone who presented with chest pain, seems tachypneic and tachycardic, and low saturation. She's a young lady, definitely I'm dealing with PE. Definitely. They love PE, by the way. So once I've got chest pain, either this chest pain in station 5 or in station 2, what could be my brain map for the chest pain? The first thing that I have to ask about it, in skin changes. So you have to think anatomically, by the way, starting from the skin. Any skin changes or rash over the site. Why? Because herpes zoster as a cause of chest pain appeared previously. Once I've got herpes zoster, the C for the causes, I have to search for why this patient immune compromised. So medication and HIV risk factor. So the first thing, anatomically, skin. After the skin, muscles. So is it musculoskeletal pain and will never be the cause? After the muscles, we've got bone and the cartilage, anatomically still. Bone and cartilage, what do you mean? Osteochondritis. Osteochondritis as an association with rheumatoid arthritis appeared once in PACES. Then pleura. What do you mean by pleura? Pleuritic chest pain. Then, after the pleura, go to the middle of the chest, mediastinum, and I'm going to tell you what I mean. So, skin herpes zoster, and the trick would be risky behavior, HIV related, plus immune like lowering medication like steroids or immune suppressant. Muscle will never be the cause musculoskeletal pain. Bone and cartilage, costochondritis, which would be associated with rheumatoid arthritis and PACES, and this is the only case appeared previously. Pleura, pleuritic chest pain, think about PEAS. What do you mean by PEAS? It could be pneumonia. So the question, do you have any raised body temperature? Because the pneumonia can give the patient chest pain. Pneumothorax, ask about with the smoking and pay attention for his stature, because Marfan syndrome appeared many times as a case of chest pain. So it could be pneumothorax related to Marfan, or it could be pneumothorax related to rupture emphysematous bulli. Then the last P, the PE. Once you are thinking about PE, think about the thrombophilic risk factors. I'm going to mention them in a while. Mediastinum, I mean in the middle of the chest, the pain in the middle of the chest. Either esophageal spasm, which is extremely unlikely. Pericarditis, so ask about any recent flu-like illness, whether the patient got SLE, and whether this pain relieved after bending forward. This is the pericarditis. It could be acute coronary syndrome. So once the patient got acute coronary syndrome, ask about the ischemic risk factors and thrombophilic risk factors. The last one would be aorta, like aortic dissection will never, ever, 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 ever be the case in the PACES. However, you have to be safe and exclude this as well by asking if the patient got central chest pain, asking about trauma, and paying attention whether the patient got ankylosing or got Marfan syndrome. So this is your map for the chest pain for station 2 and for station 5 as well. So here, I have to ask about the skin. Once it's not skin, I'm going to go directly for the pleura. Do you think this pain, what's the nature of the pain is sharp? Do you think it's increasing with laughing, coughing, and breathing? Yes, absolutely, doctor. So I'm dealing with PEAS. Do you have any raised body temperature? No, it's not pneumonia. Can I know about your smoking habit? She's not a heavy smoker. She's smoking 2 cigarettes for the past 2 years. However, keep it in mind. Then, can I know your height if you are not sure whether you are dealing with average patient or high stature one? Then the PE, the thrombophilia risk factor. She's young female presented with tachycardia, sudden chest pain, so simply go for the thrombophilic risk factors. What could be the thrombophilic risk factors? The first question, do you have any history of miscarriages or do you have any history of blood clots? No. Do you have any history of a change in your water work, especially in the morning, or recurrent abdominal pain, paroxysmal nocturnal hemoglobinuria? Nope. Are you pregnant by any chance? Do you using OCP? My own case used to use OCP. And this diet's case, she's a pregnant lady. Okay? Do you have any oral sores or recurrent genital area sores? I'm sorry to ask. Do you have any past medical history that I should be aware of, like polycythemia or sickle cell disease? And sometimes if the patient elderly, you can think about active malignancy as well, and family history of blood clots, or the family history or familial condition like protein C, protein S, and factor Leiden mutation. However, she told you, I don't know my family, I'm adopted, so you can skip this. Then, if the patient presented with DVT, ask about prolonged immobilization like lung flight, or the patient sitting for long period, or hip surgery, or recent surgery, or so on. So once you've confirmed that the patient got PE, go for the cause, which is the second C for the thrombophilic risk factors. Never, ever, ever, ever tell me, especially in this case, that you don't have time, because within my own exam, I've got time to ask about all of these factors. So it's a matter of brain mapping, guys. It's the reality, and I'm realistic. And within the examination, what I've done, I've auscultated the chest used to be normal, and then I've percussed the ABCs. That's it. Okay. So we've agreed that the first C, confirm your diagnosis. The second C, think about the cause. The third C, if there is any coincided problem. What do you mean by coincided problem? I mean associations. The fourth C would be the complication, if there is any complication, and you've asked about the heart failure symptoms anyway, and you've checked for the raised JVP, which is perfect. You can, within your examination, apart from auscultating the pericardium, you can just check the bulbable too, which could be bulbable or not, depending whether the patient developed pulmonary hypertension or not. The fourth C would be for complication, and the last C, did I answer the patient's concern? Dr. Shaheen, she asked you, what do I have? This could be scarring, fibrosis, or cavity ruptured, or blood vessel problem. So you've mentioned some differential. Do you think that the patient will have acute fibrosis or acute scarring for any cause? And do you think that the fibrosis of the patient chest pain?
No, I meant that the chronic illness has become acute like that, because I didn't have any differential to answer to that.
So once you don't have differential, how to be in the safe side, do not mention something like doesn't make sense. The examiner will think that you don't know what you are dealing with. Once you don't have differential, how to answer your patient, for the time being, we've got lots of differential, and to be honest, it could be something serious, given that your oxygen level low and you've got raised or racing of your hearts. That's why we have to run urgent tests, and after that, I would be able to answer your question. Is that okay with you? Did you get that, Dr. Shaheen?
Yes, ma'am. Thank you so much for explaining this.
You're welcome. Do you have any question within this case?
Yes, ma'am. In pneumothorax, the clinical finding just said apex will be only focus, not the whole chest.
Yes, absolutely. So once you don't have time, so the main place for the air would be the apices. Like if you don't have time and you are expecting pleural effusion, you are going to percuss the paces. Okay, so once you don't have time, percuss only the ABCs, because the ABCs will give you the clue if the patient got pneumothorax, will never be in the middle zone or in the lower zone. Either it's going to be in the upper or not.
And it
Did
can
you
be,
get?
yes,
Yeah.
ma'am. It can be itself, right?
Sorry, Dr. Shaheen, I didn't get that.
Pneumothorax can be one side unilateral.
Yes, absolutely. Most of the times would be unilateral, but it could be bilateral. And the second thing is, Dr. Shaheen, you will never face a pneumothorax in paces. You will never face it. This is an emergency, and this is against the patient's welfare, just to keep the patient with non-drained pneumothorax, just to give the chance for the candidate to examine him. But you have to show that you are safe and thinking about pneumothorax by doing percussion. And you are absolutely certain that this is not pneumothorax.
So, ma'am, in paces, they don't give pneumothorax, or they can, like,
they will never bring a pneumothorax, and anyone give you a feedback that he got a pneumothorax case, unfortunately he doesn't know what he's dealing with. Most probably that the patient just got emphysematous bully, giving the patient hyperresonant chest, and he's thinking that this is a pneumothorax. So absolutely it's not pneumothorax. Anyone telling you that I faced the pneumothorax in my PACES exam, tell him that you've got zero identifying the finding.
So, ma'am, this case you said came in the what was the diagnosis in this?
PE. Okay. And I've told you my own case used to be PE using OCP, and this diet's case PE due to pregnancy. She's 30 or 32 weeks pregnant.
Hello, ma'am.
Yep.
Ma'am,
sorry, doctor.
Okay,
I'm
sorry.
really sorry, Dr. Huda. I don't mean to be rude, but usually with any case, I'm finishing the discussion with the candidate first, then I'm opening the door for the question.
Okay.
Sorry for that. Yes, Dr. Shaheen, any other concern or any other question?
No, ma'am. Thank you so much.
Okay, thank you. Perfect. Yes, Dr. Huda.
Yes, doctor, for this active malignancy, how should I ask the questions? And how should we explore?
Any malignancy, how to ask about malignancy? Weight changes, appetite changes, anemia symptoms, plus minus family history of malignancy.
Okay. Okay, thank you, ma'am.
You're welcome. Any other question?
This PNH, you told that recurrent abdominal
paroxysmal nocturnal. Ask about paroxysmal nocturnal hemoglobinuria. Do you have any change in your water work color, especially in the early morning? She will tell you cola-like. The second question, any recurrent abdominal pain because of mesenteric ischemia. So this is the paroxysmal nocturnal hemoglobinuria.
Thank you.
You're welcome. Any other question?
Madam, this pulmonary embolism, this is also an emergency. So we will get treated patient or we will get like, this is also life-threatening condition. So we also want.
Absolutely right. So, doctor, the pulmonary embolism, you've got like stages of the pulmonary embolism. It could be massive PE, so the patient has to be immediately in the ICU. The second thing, it could be subsegmental PE, so the patient will be completely stable and you will send your patient home with anticoagulants. So this is the thing. And the third thing, most of the cases of PE in the exam will be surrogates because you don't have any finding within the examination. Normal chest, normal examination, and the history only. Did you get that, doctor?
Yes, thank you.
Okay, my own case used to be one of the invigilator in the exam, but just entered as a surrogate. And I believe this dietist case as well used to be someone who's just pregnant, and they asked her to attend the exam as a case of PE, as simple as that.
Then we can get tachycardia, just tachycardia.
So even if you don't have tachycardia within your own examination, you've got from the observation that she has a heart rate of 150. Sorry, 115. Sorry. Any other question? Okay, great. So,
Ma'am,
yes.
Ma'am, could it be the case of thyrotoxicosis?
Sorry, Dr. Den?
Ma'am, could it be the case of thyrotoxicosis?
Yes, absolutely. We can discuss a case of thyrotoxicosis next week, inshallah.
Thank you, madam.
You're welcome. So, where do you need the thyrotoxicosis, Dr. Den? Station 2 or Station 5?
Ma'am, I think station 5 will be appropriate.
Okay, perfect. So we will bring thyrotoxicosis case or hyperthyroid case generally in Station 5. And if you've got any other requests, guys, please post it in the WhatsApp group. I would be more than happy to practice these cases. And the second thing that I suppose to discuss a full mock with some clinical stations, but this is a good thing, by the way. I'm not nagging. We've got lots of questions, so I think that we are losing some candidates from 150 participants. Now it's 91 only, so they are getting poor. And I think it's going to be a wise idea discussing the clinical cases next week. What do you think, guys?
Yes, ma'am. Please, we need your clinical guidance so much. Yes.
Okay, great. So, any other question, guys?
Assalamu alaikum.
Wa alaikum salam, Dr. Kabir. Yeah.
Can you please outline investigation of pulmonary embolism in this case?
Okay, perfect. How would you investigate your patient? I'd like to thoroughly examine my patient. Then going for some blood tests and imaging. What do you mean by blood tests? If you are expecting that the patient got antiphospholipid syndrome, go for the anticardiolipine and so on. So the autoimmune profile. If you are thinking about PNH, go for flow cytometry. If you are thinking about Behçet disease, it would be clinical diagnosis. There is no blood tests. If you are thinking that your patient pregnant, go for PTH, and so on. If there is no positive pregnancy like history. If you are thinking about sickle cell or polycythemia, go for blood film. So it depending upon your findings from the history. The second thing is imaging. Imaging informs of what? Either CTPA or VQ scanning, diffusion scan. So it depends whether the patient pregnant or not. So this is the main thing. How would you investigate your patient?
Sorry, ma'am. Should we do D-dimer?
Well, D-dimer, it depends, Dr. Kabir. So D-dimer, if you are thinking that the patient got PE because of active malignancy, absolutely D-dimer will never be accurate. If you are thinking that the patient pregnant, like this diabetes case, D-dimer would be absolutely rubbish. If the patient got PE, D-dimer will be absolutely rubbish. So D-dimer will exclude but will never confirm the PE. Did you get that, Dr. Kabir?
Excuse me, ma'am.
So, depending upon the case, Dr. Kabir. So, if you are thinking that the patient just got PE because she's using OCP, you can do D-dimer. So, negative D-dimer can exclude, but the positive D-dimer will never confirm. And most of the thrombophilic risk factors will give the patient positive D-dimer without PE. Did you get my point, Dr. Kabir?
Yes, ma'am. Yes, ma'am.
Is it clear?
So D-dimer is not that much important here.
Yes, D-dimer can exclude, but D-dimer will never confirm. Okay. Yes, Dr. Huda.
Yes, ma'am. This for polycythemia and sickle cell. What questions we need to ask? Polycythemia.
Clinically, any past medical history I should be aware of. So the patient will tell you, I have history of sickle cell disease or I have history of polycythemia. Simple as that.
Okay. Okay. Not that they will tell that I have this headache or.
No. Never appeared in cases like this.
Okay. Okay. Thank you.
So the only hyperviscosity symptoms appeared in cases as a part of multiple myeloma, but never appeared as a part of polycythemia diagnosis.
Okay. Okay. Thank you.
Okay, you're welcome. So thank you guys for today's session. Thank you for the all participants. Thank you for your questions. Thank you for being very patient with me. See you next week. Inshallah, and study smart. Salam alaikum.